Well, good evening, everyone. I think we'll go ahead and get started. I know you're dedicating your evening to this coffee conversation at the Lurie Center. For those of you who haven't met me through a coffee convo or through some other function, I'm Jacob Hooker, the Scientific Director at the Lurie Center for Autism. And I'm here with the Director of the MGB Biobank, Natalie Boutin. Hopefully I said that right. To tell you a little bit about our efforts to bolster representation of autism in MGB-wide efforts that really have a profound impact on the research ecosystem. Tell you a little bit about why we do that, what the process of biobanking is really for, and quite frankly, to hear from you, to get your advice on how this resonates with you, to look to you as partners in participation, if you're willing, and if you're not, that's fine. But any insight you tell us to help us tune the research that we do at the Lurie Center is really important to us, because ultimately we do this in service of family needs. And the more we hear from you about your needs and how to align with them, the better and stronger our program is. So I'm going to jump right in, but I will say, please, 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 at any point, feel free to interrupt us, ask questions through the chat function. I'll ask Kelly Dakin, who's on, just to monitor that and jump in and flag it if you prefer not to speak up. And if I, for whatever reason, lose you, just tell me to slow down or stop. Again, these are for you, not for us. So I'd rather talk with you, not at you, to the extent possible. So I want to get started, but before we begin, I wanted to start with a quote. And I think you'll see this theme as we go through the slides we prepared, and hopefully it makes some sense. This is a very old quote from Hippocrates, the termed grandfather of medicine. And I've modified the quote a little bit to be consistent with autism spectrum disorder, but I'll just read it and pause for a second. It is far more important to know what person the disorder has than what disorder the person has. And this quote resonates with me for a lot of reasons, but really make sure that we put the focus on the person rather than whatever affliction, ailment, or medical condition we have labeled people with. But it also says something about knowing the person. And knowing the person, to me as a scientist, really means understanding at the individual level what's occurring that we might be able to help with. And I want to use a couple examples from medicine outside of autism to kind of help you appreciate why that might be powerful. And then we'll come back to autism and the opportunity, introduce the biobank, and tell you a little bit about what we're trying to do. So those of you may know that medicine at times has made really big step functions, really big leaps and breakthroughs. And I would say no more in any area in modern medicine recently in the last couple of decades than in oncology. I would attribute a large part of how we've made leaps and breakthroughs in oncology to what I'll call subtyping. The ability to not just look at a tumor or something, a collection of tumors that one might call breast cancer, for example, but to really say something at the individual person level about the nature of their tumor mass. And so you'll often hear in oncology, in breast cancer, terms like ER positive, estrogen receptor positivity, HER2 positive, so Herceptin receptor positive. Triple negative, meaning there's nothing expressed there of note. And why that's super important is by knowing that, the scientific community developed specific targeting strategies But those targeting strategies would fail in clinical trials if you applied them broadly to all of breast cancer. If you took an ER positive therapeutic and you applied it across the board without measuring at the individual level the subtype, the clinical trial will fail. And I think that's an important feature of how we think about medicine and evolution, that you really have to match make therapeutic opportunities, ways to intervene and help individuals with the specific subtype of biology that they have. And it's not just unique to breast cancer or oncology, although there are many examples in oncology. It's also true in neuroscience. And the example I'll give here is in neurology in multiple sclerosis. For a long time, multiple sclerosis was one thing, at presentation, inflammatory disease that is very well characterized by MRI, where you see these white spots. You can see these, even with no expertise in MRI, you can see these glowing dots in the MR scans. But over time, there was a recognition that not every glowing spot was the same. And in fact, very subtle differences, an open ring versus a closed ring, something that looked very, very homogeneous, something very uniform versus something very heterogeneous or diffuse, was recognized to be multiple forms of what was called multiple sclerosis, relapsing, remitting, primary progressive MS. And in fact, that led to fundamentally trial designs that included certain subtypes of multiple sclerosis, and has led to now breakthrough therapies that help reduce the frequency and severity of attacks in, for example, relapsing, remitting multiple sclerosis, really moving the needle forward. In autism, it's a little bit more complicated, admittedly. It is by definition a spectrum disorder, right? So by definition, we're starting by saying it is not one thing. You guys all know that. We know that very clearly. There are many sayings that go around the heterogeneity of autism. And I think, though, even though it's a spectrum disorder, we do still have to focus on breakthroughs that really take advantage of and understand the nature of each person with ASD. And I think that's exactly what our clinicians do. When I think about what makes Dr. McDougall special, or Dr. Newmeyer, or other, brilliant psychiatrists and psychologists or primary care specialists, they think about this, right? Put yourself in the shoes of a physician that's seeing a new patient. That physician's asking himself or herself, what am I seeing? What commonalities am I recognizing from my past experience? What has worked in my past when I see an individual with these kinds of characteristics? How do I support a family by understanding the nature of that patient, that person, right? The person that I can recognize a pattern with. And why do I see some folks respond, others not? What we're trying to do as a research community is take those insights, those brilliant clinical insights that drive the clinical care that we give, and put a biological or scientific underpinning to what the physicians have intuited through decades of experience. And by doing that, we can then create subgroups of individuals who are more likely to be helped in certain ways than other, and really focus on moving the needle forward in areas for individual subtypes. In autism, though, this is kind of a fraught space, I have to admit, and there's been a long-standing tension in the nature of the spectrum disorder. In fact, there are many, 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 many review articles, editorials, parent-led, blogs that really wrestle with this notion of identity around autism, how we lump people together, how we split them apart. There was a big change, as you may know, when the major diagnostic labels changed from DSM-4 to DSM-5, taking people that are more generally considered high functioning and lumping them together. more. I can see a rationale in certain circumstances for lumping, for keeping the community together, to make sure we get access to services, to make sure we have good health equity. There's a lot of good rationale for lumping, except in my opinion, in science. If we're really going to move the needles and have breakthroughs in ways that meaningfully change, whether it's the core symptoms of autism or the negative co-occurring symptoms that families really need help with, I think we do need to really get down to the nature of the individual and really do a better job of biologically subtyping. And believe me, we're not the first to think this way or do this, and I don't want to tell you that we are, but I think we're really hyper-focused on the intuition of our clinicians driving the way we think about subtyping, rather than trying to artificially just let biology tell us what to do. So I'm almost to the biobank, I promise you. Let me tell you why I think it's important. A secret that may not be so secret to you is that research is super inefficient. And in fact, you may have been frustrated with research and scientists like me and our teams in the past, because we kind of move at glacial speeds. On the course of decades to make breakthroughs, or centuries, right? We're not super nimble day to day, week to week, or year to year. And let me just give you one reason why. There are many, many reasons, and I could spend an entire hour just talking about this. But when we have a brilliant scientist on our team with an idea, simple idea, I've got an idea, I just need some blood samples and clinical records to answer my question, to chase my idea. What we then have to do, what that PI, principal investigator, has to do, motivate their team, and they have to document the idea, submit, get approvals, make sure we go through ethics committees, get the approvals needed, have the funding, go advertise, right, to you, our families, make sure we can recruit you in, go through study visits. That's a huge, burden to families to come in and do this with us, for us, in partnership. And then we analyze the data, and that process can take years, literally years, for one idea, from idea to data and meaning. And the problem is, if you amplify that out, right, because no single idea is actually that good, right? We need a lot of shots on goal. Imagine amplifying that for every idea running through that same multi-year cycle. Not only is that time inefficient, look at all the burden it places on families, right? It places this tremendous burden for all these recruitments and study visits and expectation of time. And it's hyper inefficient, right? Because the study procedures, how many times have you answered the same questionnaire, the same psychometric test, the same thing? I mean, geez, we guys, we put you through this over and over, and I think it's unfair. So what we're trying to do is find ways to limit that time requirement and maximize the potential investment you guys are making with your time as families for us. And so, the model of a biobank or other things that we're doing akin to a biobank is really simple. It's change that efficiency, right? Let's get the approvals up front for a larger collection of scientific ideas that we don't even know yet. We don't know what science question one of our brilliant investigators is going to ask 5 years from now. But if we're smart, we can talk about methods that allow us to store opportunity, to store data, to store biosamples, as we're going to talk about. And then when that idea comes, right, we already have ready access to the approval, the consent, the buy-in from families, and can very quickly execute within weeks to months, get to the same point that we would have on the time course of years. So that fundamentally is what the biobank and things like it are trying to achieve. And I'm going to tell you just a little bit about biobanking in the handoff to Natalie, who'll tell you about what makes the MGB biobank quite special. But biobanking is just a really simple concept, right? You go to a bank and you put money in and you can take that money out. Biobanking is just biological samples. And there's all sorts of these. It can be tissue or blood or urine, stool, saliva, breast milk, baby teeth. I'm going to tell you a really cool project about baby teeth toward the end. We're really focused right now in partnership with the MGB Biobank on blood. And that's because we can learn in today's technological landscape an absolutely tremendous amount about the biology and biochemistry occurring in an individual person through blood. And that's because blood carries all sorts of interesting things. It carries hormones, metabolites from your diet, metabolites from your microbiome, immune cells that modulate inflammatory response. It carries fats and lipids like cholesterols. It can tell us about what's happening in the brain, because even though the brain is compartmentalized, it is still perfused by blood, and it still gets its energy from blood, and it still drains lymphatically back to blood. But we get a whole collection of information from a single sample, and that single sample is pretty accessible, right? It's not always easy, and we'll talk about this, to get blood samples from every individual with autism. But comparatively to other biosamples we might need, given the rich information it provides us, it's worth it if we're smart, if we draw it infrequently and we maximize the utilization of the samples. So I'm going to pass over to Natalie, let her tell you about the biobank, and then come back and we'll have some Q&A.
Thank you, and thank you so much for inviting me. I'm thrilled to be here. So my name's Natalie, and I'm the program director at the Mass General Brigham Biobank. Next slide, please. So at the highest level, the biobank is research infrastructure that serves the research community at Mass General Brigham by providing them with samples and data generated from the samples. Right now, that means genomic data that was generated from DNA, but soon it will also be biomarker data that was generated from the blood samples. And to the point that Jacob just made, the entire reason for existing of the biobank is to accelerate research and make it a lot more cost effective. We're basically creating economies of scale for hundreds and hundreds of research studies that can now rely on us to get samples and associated data, instead of having to go out and recruit patients themselves and have to go through the entire same process that the biobank is able to do, then serving a large number of researchers. So we started recruiting patients in 2012, and we're going to hit a really important milestone in a couple of months, which is that we'll have recruited 150,000 active participants into the biobank. So it's become a pretty big resource that is used a lot at Mass General Brigham. We've distributed more than 225,000 samples to research studies. And we're now expanding the amount of data, the kind of data that we make available to researchers by creating biomarker data that is used in a lot of different kinds of research, in addition to the genomic data. An important part about the biobank is that the samples and the data we produce are linked to the electronic health record. So that means that it's really a really rich data set that researchers can use for all of their studies. Next slide, please. So as of now, we've distributed samples or genomic data to more than 550 studies, covering a really wide array of disease areas. And if you go to the next slide, I attempted to create a word cloud using the key focus areas of just those studies that actually resulted in a published academic paper. So I could create a different word cloud that shows all the distributions, but for this exercise, I was looking at the ones that actually resulted in a finding that was peer reviewed and published. And so you can see that there's a lot of different kinds of disease areas that are covered that are enabled by the biobank. The reason we're working with the Lurie Center is because you'll notice ASD is not on there, right? And that's a gap that Jacob and his team had identified, which put us together to do a collaboration to try to increase representation of specific phenotypes within the biobank. You can see from the word cloud, there was a ton of COVID research that happened in 2020, 2021. The entire biobank was completely refactored in weeks. It felt like days to be able to collect a lot of samples from people who were sick with COVID at the beginning of the pandemic. And we built a really large resource of COVID samples that have also been used in a lot of publications. Next slide, please. So there's 4 components to the biobank operation. Recruitment is the mechanism to approach patients in the clinical setting primarily, and to ask them to join the study, going over the terms of the consent form, the risks of participation, and asking them to provide their informed consent. The second is the collection of the blood draw, which can also be done in a number of different ways. The third is the management of the samples, managing them in freezers and generating data from the samples through genotyping or sequencing or other assays to obtain biomarker data. And the fourth component is the management of workflows to distribute the samples and the data to Mass General Brigham investigators. And the samples and data are de-identified most of the time for distributions. It is possible for investigators at Mass General Brigham, for researchers to get approval from the ethics board to do identified research. So that also does happen within the biobank. Next slide, please. So these are the terms, the key terms of the consent form when people join the biobank. They agree to provide samples and data for use in broad-based research. So that's really one of the key terms, that the samples could be used for any research that is happening at Mass General Brigham, and not just research in one specific disease area. The second term is that the data and samples are associated with the electronic medical record, which really is what adds the value to them for researchers, because it's not just a blank sample, it's a sample of somebody they know, what test results they've had, what diagnoses they've had, and they can access that rich record that is stored electronically at Mass General Brigham. There's also an agreement that we might recontact somebody in the future to ask them to join another study. We have a process for returning genetic results to people who participate in the biobank when we find that these are medically actionable. So there's a whole very rigorous, very reviewed process there, where if we find a result in our work that a great example of that is if somebody has one of the genetic variants that leads to increased risk of breast or ovarian cancer. If we find that, we would actually reach out to that participant and tell them we found something that needs to be clinically validated, and we would work with them to get that result and to go see a doctor who could help them with that result, because there is a plan, a course of action clinically you can take if you have something like that. And the last thing is we ask people to fill out a brief survey to add some additional information on top of what we have in the electronic health record. So that's the biobank in a nutshell. We're trying to accelerate research. We're trying to make it cheaper for researchers, which greatly increases the amount of research that can be done. And we're thrilled to be collaborating with the team at the Lurie Center. We started recruiting in April. And recruiting is ongoing. And I just checked the numbers while Jacob was talking, and we're about to get to 50 participants very soon. So it's really going great. And that's the end of my slides, but I'm looking forward to the rest of the conversation.
Thank you, Natalie. And I do see some questions coming into the chat that we can take on in just a minute. I will say that obviously not everyone wants to participate in this. I do think that our goal was to provide representation. When I took a look at the biobank data and what samples existed for individuals with autism, I think there was something north of 40, 42 or 45. And it's just not enough to meaningfully participate in the scientific enterprise. One of the largest research medical hospitals in the world, and autism kind of gets left out just because we don't have sample representation in such key things like the biobank. That said, it's hard. I get it. Who wants more to do as a family? It's hard enough just to get up and get kids dressed into school and to deal with dinner, much less a special visit to, have an IV catheter put in and have a blood draw. We recognize that, and we're trying to align it in ways that might actually help families in other realms. Obviously, getting a blood draw is sometimes an important health requirement, right? To measure something that may be important for your child or loved one's clinical need, and yet everyone can have a fear of needles, and it's particularly difficult for individuals with autism who may have more difficulty with the setting, the unfamiliar approach, or of course difficulty communicating to be able to express their challenge. So we do have a great team of support staff, psychologists and beyond, who can really help families. You may know some of the folks, including sessions like needle desensitization training and other medical desensitization processes. And I just added a note here that if cost is ever prohibitive for families, we are willing, from our research funding to help offset this to make those experiences more approachable, and to also then have that training available to people for the clinical care that they need. It is important that we get the word out, and one of the asks we have of our families is just to help spread the word. We were very fortunate that this got picked up, our efforts got picked up by the Boston Globe, and I think it was on Thanksgiving morning. There was a highlight on the front page of the Boston Globe about our efforts. So it's one way that you can help distribute and just encourage families to consider participating. And as I mentioned at the outset, we're not the MGB Biobank is one of many biobanking strategies, and in particular leverages blood. One thing that you may have in your drawer at home or in some treasure chest are infant baby teeth, exfoliated teeth. Playing your role as tooth fairy is fun, but then those teeth just exist. And it turns out, because those teeth are being formed below the gum line, even in gestation, when an infant, prior to birth, information about their the history biologically is encoded in things like stress lines and teeth. We're really fortunate to have a collaboration with Aaron Dunn, who is very eager to exploit and understand how we look back in time. How do we look back at the history of an individual by examining the biochemistry encoded in the developing tooth, which occurred 5 or 6 years prior to when that tooth exfoliated? It's a brilliant project. Erin is an amazing collaborator and just a really smart person in how she thinks about this, and has become a local celebrity as our resident MGB, MGH tooth fairy. So I would just encourage you to also consider, if you've got a drawer full of teeth, that maybe Erin could make some use of those in our collaboration. So I'll throw some frequently asked questions out. I put these up just because I didn't know if people would be weighing in already, but we can also skip these and go straight to the questions in the chat. I'm going to unshare my screen after I go to my thank you slide just to say thank you formally, so that we have an opportunity to be able to connect on video at least. But if at any point someone wants me to pull a slide back up, please ask, and I'm happy to. So I'm just going to end with gratitude. We really do look to parents and families to help guide our research mission. If this doesn't resonate with you, tell us. If this is something you can help us with, please help us. If you think we should be focused somewhere else, do not hesitate to tell us. We're here for you. That's what gets us up every day and keeps us motivated to come to work and work incredibly hard in the service of the future of care and innovation in autism.